Halo, selamat good afternoon, Dr. Dusa. Good afternoon, Dr. Wisnu Pandey. How are you?
Hello, Prof. Everything's good.
Yeah,
How are you, Prof?
you. Thank you, fine, thank you. And we will start on time, okay? We still have
Yeah, around
maybe
10 minutes.
15 minutes left. Okay?
Yes. Good evening, Dr. Paksi Satyagraha. Thank you for accepting
Good,
our invitation.
good evening, Dr. Pandey Vishnu, Professor Mariawan. It's a great honor to be involved in ITS. I'm a new
Thank
member.
you. Thank you
My
for
pleasure.
joining this. For
My
joining.
very great pleasure, sir. Thank you very much.
So this webinar will be moderate. Will be conducted by Dr. Pandey Vishnu, and we have 3 or 4 speakers. And after that,
For speaker, Professor.
yeah, 4 speakers. And then what about the finalists? Is the already joined?
I'm not quite sure, but Dr.
Oh,
Maria
oh,
has already
yeah.
contacted
Good.
Dr. Oka also and Prof. Pillai. I have to double check first, Prof.
Okay. We still have 10 minutes, so let's check it. While I'm
Selamat malam, Dr. Oke. Good evening, Dr. Ana Agung Gede Oke. Very nice to see you here.
Masih mute?
Good evening, Dr. Okte, my great teacher.
Good
Good to
evening,
see you.
Dr. Paksi. Pandai Wisnu, itu backgroundnya saya tak bisa masuk.
Ya, Dr. Oke sudah dapat dari ini, dok, sudah dikirimkan, dok ya?
Sudah.
Setelah itu di ini, dok, di videonya.
Di video ya.
Video ada diklik icon di samping video.
Terus
Setelah itu
background
choose.
effect-nya, adjust ya.
Ya, choose virtual background, dok.
Choose virtual background.
Setelah itu ada tanda tambah. Setelah itu di ini, dok, di videonya. Di video ya. Video ada diklik icon di samping video. Setelah itu background effect-nya, adjust ya. Choose virtual. Choose virtual background-nya, dok. Tanda tambah setelah itu.
Good evening, selamat malam, Dr.
Good evening.
Setio, also my senior from Malang.
Dokter Paksi, ke undangan, ada undangan.
Sampun, Dok. Ini melipir ini.
Saya paling ini.
Kak, HP-nya mana?
Dr. Pandey, it's now on time. We start. Who already available? We start with that speech.
Yes. Okay. Thank you, Prof. Sri Maliawan. So, good evening, everyone, and welcome to our webinar. So this is the webinar from ICS Indonesian section. So for today's webinar, the entitle for this webinar is the pelvic and urogenital trauma. So I want to say thank you to all the participants and also all the speakers who accepted our invitation to be here. So basically, this is the first webinar for now, and we try to make this webinar in like monthly basis. So basically, we try to search any interesting idea or any interesting topic for next month also. So for today webinar is the pelvic and urogenital trauma. We have 4 speakers today. Not only talking about the clinical aspect of pelvic and urogenital trauma, but also we have one speaker, Dr. Setio Sugiharto. He will talk about the legal and ethical issues in trauma care also. So without further ado, so I will invite Professor Sri Malyawan. He's our boss now. He's the president of ICS Indonesian section. To give the opening speech. Please, Professor Sri Malyawan. Still mute, Prof. Can you unmute yourself?
Okay, thank you, Dr. Pandiwisnu. Good morning, good afternoon, and good night, for especially to the participant and also for all of the webinar speakers.
Prof, kemut, Prof. Prof.
Still mute, Prof. Professor Sri Malyawan,
Okay.
can you unmute yourself, right?
Okay, thank you. Sorry for the technical problems. I repeat, good morning, good afternoon, good night, especially to the participant and all of the webinar speakers. On behalf of the president of ICS Indonesian section, I would like to congratulate you on participating in the seminar and congratulations on sharing your knowledge with the speakers. Hopefully, it will be useful. And this is the second webinar since my leadership. And this webinar is rather special because it is accredited by the Minister of Health. Hopefully, the participant can take part in this webinar well. This seminar is planned to have a maximum 200 participants. But those who register are more than 1,500 people. So that the community is forced to have some difficulty to prioritizing FICS members. Because this webinar is free of charge, FICS members are prioritized. I hope this webinar will run smoothly and the program of FICS Indonesian section that has been made for a year is trying to be followed. The first priority is to improve the organization and then carry out the program that we have prepared. For members who want to become speaker in the next webinar, they can submit a title along with the PowerPoint, because to take care of the accreditation to the Ministry of Health, it must be completed to determine the number of SKP. Hopefully, under my leadership, FICS Indonesia will be more advanced and can participate in the National Health Program. Last but not least, please save the date. On 16th of November, there will be offline FICS one-day seminar. Will take place at Faculty of Medicine Udayana University. We already confirmed 7 overseas speakers, and then we are waiting for the Indonesian faculty. So please communicate with the committee who want to speak in that offline seminar. Thank you for your attention. Thank you for your participation. Thank you for all of the distinguished speakers. And I bring back the screen to our moderator. Thank you.
Thank you, Professor Sri Maliawan, for the nice introduction and opening speech. As we see now, we have Dr. Guido Parget Villagra also here with us today. So I will invite him because he's the world president of ICS. I will invite him to give a message to us here in Indonesia. Please, Dr. Guido.
Good morning to everyone. I think it's good evening to you. It's good morning to me, but as a worldwide organization, we are always awake and always working. I would like to thank the organizing committee for the invitation to address this welcome message to this webinar. I guess this is a series of webinar. I've been participating in at least 2 of them before. And this is a very, very, very interesting activity the Indonesian section does. It's worthwhile imitating by all the other sections of the ICS. So I would like to congratulate everyone in the Indonesian section for this activity. Now the Dr. Sri Maliawan is the actual president of the ICS Indonesian section, so congratulations to you also. You know that as a world body, we are going through difficult times. We have a lot of problems, especially because there's a decrease in enthusiasm in our fellows. And we depend a lot on the support and the leadership of our fellows. The world leadership is focused to deal with this circumstance. And one of the principal goals during my term is to significantly increase our membership. And this is a really difficult task, but I think we can do that by increasing our offer of opportunities and participation to the fellows. That's why I'm very happy today being with you here, because the Indonesian section and its leadership is an example that our goals are possible with commitment and leadership. You know that the Indonesian section has approximately 48 years. You have been conducting this series of webinars. The membership in your section has grown significantly in the past 4 years. You conducted also the Pacific Federation Congress in 2022. And you have very good leadership. I know Professor Paul Tahalele. He has been a long-time member of the World Body Governance for several years. Now, Professor Arifin, who is doing an excellent job as a Federation Secretary. So this is very important and fundamental point. The focused, enthusiastic leadership that the Indonesian section has developed over time. So this is the essence of fulfilling our membership growth goal that I mentioned before. I really commend the Indonesian section leadership for organizing this series of webinars. In this case, it's a very, very, very interesting theme, that is the pelvic and urogenital trauma, which I'm certain will be very informative and helpful in staying updated in these themes. I would again especially thank Professor Arifin, Professor Maliawan for inviting me to give this message at this webinar. I'm very, very happy with the Indonesian section. I would again want to congratulate you. You're an example for the other sections. Keep with your work. I give my best wishes for a very productive and enjoyable seminar. The numbers that Professor Maliawan gave are already a success. It's incredible the number of registries you have. So I hope that this section continues its excellent work and continues to be an example for the rest of the sections of the world. Thank you very much.
Thank you, Dr. Guido, for the encouraging message to us here in Indonesia. So for the next speech, it's supposed to be Mr. Max Downham. But as far as I know that he's not here up until now. Can someone, Professor Sri Malawan, can you confirm if Mr. Max Downham here?
Yeah, he tried to join, but
Right.
there is some difficulties there. Maybe we
Right,
can
okay.
continue.
Oh,
Skip.
Okay, right, okay, right. So because Professor Max Downham not here with us today, so we just move on with our main session. For the first speaker, so we will have 4 speakers as I showed you earlier. So for the first speaker, we will have Dr. Setio Sugiharto. He will talk about the legal and ethical issues in trauma care. He is a digestive surgeon who works in Saiful Anwar General Hospital, Faculty of Medicine, Brawijaya University. Not only as a digestive surgeon, he also obtained a bachelor, a master, and also PhD in law. Please, Dr. Setio Sugiharto.
Good evening, the professor and colleagues. Whom I brought tonight, I will talk about ethical and legal issue in emergency trauma patient. I will present my presentation in Indonesian because it relates the interpretation of article.
Yes, please, Dr. Setio.
Sudah kelihatan? PPT-nya sudah kelihatan?
Untuk slide-nya belum, dokter. Mohon maaf. Baru share screen untuk laptopnya saja.
Please.
Can you open the PowerPoint,
Open the
and
PowerPoint.
then?
Ya.
Not yet open.
Sudah kelihatan?
Belum, dok.
Ya,
Ya, sudah.
Ya.
Silakan, dokter.
Terima kasih atas waktunya. Pada malam ini kami mengembangkan problematik etik hukum pada perawatan pasien gawat darurat trauma di era berlakunya Undang-Undang 17 tahun 2023. Jadi problem etik hukum pada pasien-pasien trauma adalah banyak ya. Bahwa di sini problemnya adalah pasien itu memerlukan penanganan yang segera. Kemudian kondisi-kondisi tertentu, misalnya status pasien itu kadang belum jelas ya, dia diantar oleh relawan, diantar oleh masyarakat, dan lainnya. Sehingga ini juga menimbulkan hal yang tidak mudah bagi yang menangani. Kemudian juga pada pasien-pasien ini sebagian ada pasien yang tidak sadar. Nah, sedangkan di sini memerlukan suatu tindakan ya, tindakan yang segera. Pasti tidak sadar. Bagaimana tentang masalah imunitasnya? Dan juga bagaimana tentang masalah pemenuhan hak-hak yang harus diberikan pada pasien ini, dan juga bagaimana menjaga privasi data pribadi dari pasien, di mana pasien ini adalah pasien yang identitasnya tidak jelas, kemudian juga kadang-kadang dia itu tidak ada identitasnya atau diantar oleh relawan atau yang lainnya. Di sini akan kita bahas tentang berdasarkan regulasi yang berlaku pada saat ini, baik Undang-Undang 1723 atau juga Peraturan Pemerintah tahun 24 tahun 2024. Ini bahwa kondisi pasien trauma adalah sebagian adalah pasien yang multi trauma yang ditangani oleh beberapa disiplin ilmu, di mana kadang memerlukan suatu peralatan yang sangat kompleks, misalnya perlu ventilator, perlu dilakukan tindakan operasi, dan di sini dokter sebagai dengan keilmuannya dituntut untuk harus segera melakukan tindakan medis berisiko tinggi dan menyelamatkan nyawa pasien. Di sini kadang-kadang hasil yang diharapkan itu kesembuhan itu juga kadang tidak terpenuhi, sehingga di sini menjadi problem masalah-masalah etik mediko legal dalam pasien-pasien yang seperti ini. Ini sebelum kita menginjak ke masalah masalah legal, kita harus paham mengenai bagaimana perubahan pola interaksi hubungan antara dokter dan pasien. Pada masa lampau itu hubungannya adalah hubungan paternalistik vertikal. Dokter merasa atau berada di atasnya lebih dominan, dan pasien-pasien menyerahkan semuanya kepada dokter. Sedangkan sekarang adalah terjadi perubahan pergeseran dalam penanganannya. Barisnya adalah pasien center care, dan hubungannya adalah hubungan kontrak horizontal. Pasien memutuskan suatu keputusan tentang tindakan diagnostik itu berdasarkan setelah mendapatkan suatu edukasi informasi yang cukup. Hal ini sesuai dengan pasal 4 Undang-Undang 1123 huruf H dan J. Kemudian problem-problem masa itu legal pada pasal adalah bagaimana tentang masa informasinya. Kemudian juga bagaimana tentang pemenuhan hak-haknya. Dan juga bagaimana menjaga privasi kerahasiaan data dari pasien tersebut. Hal ini tertuang dalam pasal 274 Undang-Undang 17 tahun 2023. Bahwa di sini ada beberapa unsur ya. Pertama, bahwa pemberi pelayanan kesehatan harus sesuai dengan standar profesi, standar pelayanan profesi, standar prosedur operasi, dan juga etika operasi serta kebutuhan kesehatan pasien. Di sini adalah hak-hak pasien yang harus dipenuhi. Kemudian juga pada huruf B, pasien memperoleh persetujuan dari pasien, keluarga atas tindakan yang akan dilakukan. Ini disebut informed consent. Kemudian pada huruf C, senantiasa menjaga kerahasiaan pasien. Kemudian D, membuat dan menyimpan data, catatan atau dokumen tentang pemeriksaan, asuhan, dan tindakan yang dilakukan. Marilah kita bahas pertama-tama mengenai informed consent. Informed consent adalah persetujuan yang diberikan oleh pasien atau keluarganya kepada dokter untuk melakukan tindakan dokter tertentu setelah menerima informasi yang jelas dan rinci. Tujuannya apa? Tujuannya supaya dokter memiliki kepastian bahwa pasien telah mengerti informasi yang diberikan dengan bahasa-bahasa yang mudah dimengerti oleh pasien dan keluarganya. Yang sering terjadi adalah pasien dan keluarga tidak paham dengan bahasa-bahasa yang diberikan, atau juga saksi-saksi yang tanda tangan itu kurang lengkap. Dan ini sangat berpotensi terjadinya suatu masalah-masalah etik dan mediko-legal. Ini bahwa pada pasal 293 bahkan bahwa setiap tindakan pelayanan kesehatan yang dilakukan oleh tenaga medis harus mendapatkan persetujuan. Persetujuan sebagai dimaksud pada ayat 1 diberikan setelah pasien mendapatkan penjelasan yang memadai. Penjelasan sebagai dimaksud pada ayat 2 paling sedikit mencakup masalah diagnosisnya, indikasinya, tindakan pelayanan kesehatan yang dilakukan, tujuannya apa, risiko-risiko dan komplikasi yang mungkin terjadi, alternatif tindakan lain dan risikonya, risiko apabila tindakan tidak dilakukan, dan juga sampai pada masa prognosis jika setelah memperoleh tindakan tersebut. Bagaimana pada pasien trauma, pasien tidak sadar, atau juga pasien tidak ada keluarganya, atau keluarganya itu ada tapi juga ikut dalam atau mengalami trauma. Ini juga merupakan pertimbangan-pertimbangan yang harus dipikirkan. Kemudian pasal-pasal di dalam Undang-Undang 17 tentang masalah informed consent, yaitu dalam Undang-Undang 1723 tentang kesehatan terdapat ketentuan eksplisit, yaitu pada pasal 274 bahwa yang menegaskan kewajiban dokter untuk mendapatkan persetujuan tindakan medis dari pasien atau keluarganya sebelum melakukan tindakan medis. Pada pasal 293 ayat 1 disebutkan bahwa yang menyatakan bahwa setiap tindakan medis yang dilakukan secara individual oleh seorang dokter harus didahului dengan memperoleh persetujuan dari pasien tersebut. Kemudian juga pada pasal 293 ayat 5 menegaskan bahwa sebelum dikerjakan tindakan bersegi informed consent terus harus didapatkan. Bagaimana tentang pasien-pasien yang tidak ada keluarganya, pasien yang tidak sadar? Ini harus dipikirkan betul. Pada pasal 174, fasilitas kesehatan milik pemerintah pusat, daerah, dan masyarakat wajib memberikan pelayanan kesehatan bagi seorang yang berada dalam kondisi gawat darurat untuk melakukan penyelamatan nyawa dan penjagaan stabilitasnya. Dalam kondisi gawat darurat, sebagaimana pada ayat 1, fasilitas kesehatan, daerah atau masyarakat dilarang menolak pasien atau meminta uang muka, serta dilarang mendahulukan sebuah transaksi sehingga menyebabkan tertundanya. Ini bertujuan apa? Bahwa dalam kasus-kasus gawat darurat, maka fasilitas kesehatan harus menolong dari pasien tersebut. Ini pada pasal 275 ayat 1, pada pasal 275 pada ayat 1 disebutkan bahwa tenaga medis dan kesehatan yang menjalankan kesehatan wajib memberikan pertolongan pertama kepada pasien dalam keadaan darurat dan atau bencana. Pada pasal 2-nya, pada ayat 2-nya, tenaga kesehatan dan tenaga kesehatan yang memberikan pertolongan kesehatan dalam rangka dalam kesehatan darurat dan atau pada bencana dikecualikan dari tuntutan ganti rugi. Ini adalah dari pasal 275. Sedangkan pada PP-nya sebutkan bahwa rumah sakit dilarang menolak pasien dan atau minta uang muka serta dilarang mendahulukan segala urusan sehingga menyebabkan tertundanya pelayanan kesehatan tersebut. Ini dilema pada pelayanan kesehatan pada pasal trauma pada pasal 275 dalam keadaan gawat darurat pada pasal 275 ayat 1 di sini tentang kesehatan menyatakan bahwa kewajiban bagi tenaga kesehatan dan kesehatan yang berpraktek di fasilitas kesehatan untuk memberikan bantuan pertolongan pertama pada pasien yang memiliki kondisi gawat darurat. Pada pasal 293 bahwa persetujuan secara tertulis wajib diperoleh terlebih dahulu sebelum melakukan prosedur invasif atau tindakan yang mengandung risiko tinggi. Ini adalah hal-hal yang berhubungan dengan pasal-pasal yang mengharuskan untuk memberikan pertolongan. Pada pasal 75 Undang-Undang Kesehatan 1723 jadi adalah harus memberikan bantuan awal darurat kepada pasien yang sedang mengalami penyakit kritis. Kemudian dari segi etika, ini sejalan dengan pasal 13 Kode Etik Kedokteran yang juga menyebutkan bahwa kewajiban dokter untuk melakukan pertolongan darurat sebagai suatu tugas kemanusiaan. Dari segi profesional, bahwa tindakan pemberian pertolongan ini merupakan tanggung jawab profesi seorang dokter yang memang memiliki keahlian dan kompetensi dalam menghadapi situasi yang demikian. Ini adalah dasar-dasar bahwa kita harus menolong pada pasien-pasien yang mengalami trauma, walaupun toh dia tidak sadar dan tidak ada keluarganya. Ini bahwa kendala-kendalanya di sini ada kendala pada pasien maupun pada keluarga. Pada pasien, di sini pasien kehilangan adanya kompetensinya, pasien dalam kondisi tidak sadar, atau juga pasien tidak mampu memahami edukasi yang kita berikan. Untuk kendala pada keluarga, di sini perlu tindakan cepat, tidak adanya cukup waktu untuk memperoleh informed consent, atau juga tidak ada keluarga yang bertanggung jawab, status pasien tidak jelas, identitas tidak diketahui, atau juga keluarga bertanggung jawab ada, tetapi tidak berada di rumah sakit atau tidak bisa dihubungi, atau juga keluarga yang bertanggung jawab ada, tetapi belum bisa atau tidak berani memberikan informasi, atau juga keluarga juga ikut serta dalam korban tersebut, sehingga ini adalah merupakan kendala-kendala di dalam pemberian konsen pada pasien-pasien yang mengalami kedaruratan dalam trauma. Ini beberapa perlindungan bagi seorang dokter di dalam menangani pasien trauma. Pada pasal 4 disebutkan bahwa hak untuk memutuskan mandiri hilang pada pasien kondisi darurat. Pada pasal 80 ayat 3 menyatakan bahwa dalam keadaan gawat darurat tindakan medis boleh dijalankan tanpa memerlukan persetujuan terlebih dahulu. Pada pasal 293 ayat 9 menegaskan bahwa bila pasien tidak memiliki kapasitas untuk memberikan persetujuan dan menghadapi kondisi yang mengancam jiwa tanpa adanya wali yang bisa meminta persetujuan, maka persetujuan untuk tindakan medis itu tidak diperlukan. Ini adalah beberapa pasal-pasal yang menjadi perlindungan bagi seorang dokter dalam menangani pasien trauma, walaupun pasien dalam kondisi tidak sadar atau juga pasien yang tidak ada keluarganya. Ini bahwa setiap tindakan pelayanan kesehatan orang yang melakukan trauma medis harus mendapat persetujuan. Bahwa pada pasal 10 tindakan sebagian dimaksud pada ayat 9 dilakukan berdasarkan kepentingan terbaik pasien yang diputuskan oleh tenaga medis dan kesehatan yang memberikan pelayanan kepada pasien. Ini dasar perlindungan hukum bagi dokter yang menangani gawat pasien trauma, yaitu pasal 4 ayat 23, pasal 80 ayat 3, kemudian juga di sini pasal 293 ayat 9 tentang kesehatan, prinsip sepakat bahwa untuk menyelamatkan jiwa pasien dalam situasi gawat darurat tidak diperlukan informed consent. Dokter berkewajiban untuk memberikan bantuan meskipun pasien dalam kondisi tidak sadar dan tidak dapat memberikan persetujuan atas tindakan tersebut. Di sini ada namanya doctrine of necessary, yaitu asas hukum yang membenarkan pelanggaran hukum dalam kondisi gawat darurat atau terpaksa. Intinya apa? Di sini kita sebagai seorang dokter harus berusaha untuk menyelamatkan pasien tersebut. Ini jadi penerapan doktrin of necessity dalam kondisi gawat darurat medis di mana dokter tidak memiliki persetujuan tertulis dari pasien berlaku penerapan doktrin of necessity, yaitu pertama yang harus dilakukan oleh dokter dalam situasi gawat darurat tindakan tersebut untuk menyelamatkan nyawa atau mencegah kerusakan kesehatan yang serius. Kemudian juga di sini karena waktunya mendesak, maka tidak ada waktu untuk kemungkinan untuk mendapatkan hormon konsen. Dalam keadaan di mana membiarkan seorang mengalami kematian karena tidak ada inform konsen dianggap lebih melanggar moral, profesi, dan etis dibandingkan dengan melanggar standar-standar yang berlaku. Ini, tapi walaupun bagaimanapun pasal 293 ayat 11 Undang-Undang 1723 tetap kita harus berkewajiban untuk melakukan edukasi setelah tindakan selesai. Jadi setelah pasiennya sudah sadar, sudah ada keluarganya, maka kita tetap diwajibkan untuk memberikan edukasi, memberikan komunikasi. Jadi tindakan tersebut harus segera dikonfirmasi kepada pasien setelah pasien cukup cakap atau yang mewakili sudah hadir dengan tujuan pertama, sebagai penghormatan atas otonomi pasien untuk tetap terlibat dalam pengambilan keputusan tentang dirinya sendiri. Yang kedua ada sebagai upaya mewujudkan transparansi dalam hubungan antar dokter dan pasiennya, dan juga sebagai upaya membangun komunikasi yang jujur, terbuka, guna menumbuhkan kepercayaan pasien keluarga ke dokter. Atau juga 4, sebagai upaya memenuhi prinsip etika medis, di mana dokter mempunyai kewajiban untuk menginformasikan secara jelas kondisi pasien, terapi yang diberikan, dan juga harapan kesembuhan dari pasien. Atau juga sebagai upaya pemenuhan kewajiban hukum dokter dan sebagai upaya untuk mencegah jika sewaktu-waktu terjadi suatu sengketa hukum karena masalah-masalah tidak adanya keputusan tersebut. Ini tentang pemenuhan hak pasien. Di sini perlu tentang bagaimana kita harus memenuhi hak pasien walaupun toh pasien itu kondisinya tidak ada keluarga, tidak sadar, tidak ketahui identitasnya. Bahwa di sini adalah harus terpenuhi pemenuhan hak atas layanan yang baik, pemenuhan terhadap informasi tentang sakitnya, dan juga atas kerahasiaan pasien dan data pribadinya. Walaupun toh pasien itu tidak jelas datanya, kita tidak boleh tidak boleh serta-merta mau meng-share dan lainnya itu. Ini adalah merupakan bagian dari pemenuhan hak-hak dari pasien. Ini pada pasal 4 Undang-Undang Kesehatan 17 tahun 23 disebutkan bahwa pertama pasien mendapatkan informasi dan edukasi tentang kesehatan yang seimbang dan bertanggung jawab, mendapat pelayanan kesehatan yang aman, bermutu, terjangkau, agar dapat mewujudkan derajat kesehatan yang tinggi-tingginya. Atau juga pasien mendapatkan perawatan kesehatan sesuai dengan standar pelayanan kesehatan, pasien menentukan sendiri pelayanan kesehatan yang diperlukan bagi dirinya sendiri serta bertanggung jawab. Dan juga menerima atau menolak sebagian atau seluruh tindakan pertolongan yang akan diberikan kepadanya setelah menerima dan memahami informasi mengenai tindakan secara lengkap. Dan juga memberi kerahasiaan data informasi kesehatannya. Kemudian di sini juga pasien memperoleh informasi data kesehatan dirinya termasuk tindakan pengobatan yang telah ataupun yang akan diterima dari tenaga medis atau tenaga kesehatan. Ini bahwa di dalam pernah sudah penelitian bahwa kalau hak-hak pasien terpenuhi, maka jika terjadi suatu masalah hukum, masalah kita itu akan sangat berkorelasi. Sehingga kalau pemenuhan hak pasien itu dicapai, maka dalam proses penanganan itu akan lebih mudah. Ini bagaimana menjaga privasi dan data kesehatan pasien. Pada kondisi-kondisi pasien yang tidak jelas identitasnya, yang dia itu tidak ada keluarganya, itu pun juga harus tetap dijaga privasi dan data kesehatannya di dalam penanganan pasien tersebut. Ini bahwa perlunya dokumentasi mencegah timbulnya sengketa medis pada kondisi gawat darurat trauma. Dokumentasi tindakan kedokteran yang baik menjadi sangat penting manakala dokter melakukan tindakan medis atas dasar presumption of concern. Pada pasien dengan gawat daruratan ditekankan oleh Undang-Undang 1723 pada sebagai berikut. Pada pasal 24 huruf D yang menyebutkan bahwa dokter membuat dan menyimpan catatan dan atau dokumen tentang pemeriksaan, asuhan, dan tindakan dilakukan. Pada pasal 300 ayat 1 menyatakan bahwa dalam menjalankan upaya kesehatan masyarakat, dokter wajib membuat catatan kesehatan. Karena apa? Catatan ini adalah merupakan suatu bukti hukum yang harus disimpan dan harus diamankan. Sehingga kalau sewaktu-waktu dibutuhkan, maka ini akan menjadi suatu bukti, menjadi suatu catatan yang akan membela dokter tersebut. Ini beberapa pasal-pasal yang berhubungan dengan penyuluhan data kesehatan pasien. Jadi pada pasal 77 Sebutkan bahwa setiap fase kesehatan harus menyimpan rahasia kesehatan pribadi pasien. Pelayanan kesehatan dapat menolak mengungkapkan segala informasi kepada publik yang berkaitan dengan rahasia kesehatan pribadi pasien, kecuali berdasarkan ketentuan sebagai dibahas pada pasal 4 ayat 4. Ketentuan lebih lanjut mengenai rahasia kesehatan diatur dalam peraturan pemerintah. Pada pasal 275 bahwa tenaga medis dan tenaga kesehatan dalam menjalankan proses kesehatan wajib menjaga rahasia kesehatan pasien, wajib membuat dan menyimpan catatan dan atau dokumen tentang pemeriksaan, asuhan dan tindakan yang dilakukan. Walaupun pasien tidak sadar, tidak ada keluarganya, kita wajib untuk menyimpan, untuk membuat data-data pasien itu menjadi aman. Nih, terima kasih. Mungkin paparan dari saya cukup sekian.
Terima kasih. Thank you, Dr. Setio,
Thank you.
for the interesting lecture about the legal and ethical issues in trauma care. So I think this is very important for us also as a surgeon. Right. So we move on to the next speaker. Can I confirm Professor GWK Duarsa to give the lecture, or should I move on to the third speaker first? Because I think Professor GWK Duarsa still in the OR.
Yeah, third speaker plus, please. Thank you.
Right. Right. So for the next speaker, Dr. Iwayan Suryanto Dusak. Right. He will talk about the pelvic fracture in the orthopedic point of view. Dr. Iwayan Suryanto Dusak is an orthopedic surgeon who works in the Professor Urogenital Hospital, Faculty of Medicine, Universitas Udayana. Please, Dr. Suryanto Dusak.
Thank you, Dr. Pandey, as a moderator tonight. Good evening to all of the participants. I would like speak about the pelvic trauma.
Faculty of Medicine, Universitas.
Can I share the PowerPoint?
Yes, please, Doctor.
I would like speak about the Okay. This evening, I will talk about current management of severe pelvic fracture. Yes, as we know, the pelvic fracture mainly caused by motor vehicle accidents. Yeah, that's account about 60%. In our hospital, Ngurah Hospital, in our hospital, Ngurah Hospital, the highest incident is about 40.4% in patient age between 20 until 39 years, and also due to the motor vehicle accident. And regarding to pelvic tile penal classification, the patient is categorized as like a type A, around 48.5%, type B, 35.5%, and in type C, around 16.1%. When we talk about the pelvic fracture, especially in severe case, we must remember about the vascular anatomy of the pelvis, because as we know, in pelvic capacity, in pelvis, there was a lot of blood vessel, including the artery, vena, and also nerve. Pelvic fracture can classify regarding to young Burgess. Young Burgess divide the pelvic fracture into three. The first one is antero-posterior compression. Second one is lateral compression, and the last is vertical shear type. Lateral compression type. This fracture, the most common in our hospital, the mechanism of injury is a T-bone or intersectional motor vehicle accident, and sometimes the pedestrian struck by a car or motor from the side, and also the patient can fall from high and landing on the side. This lateral compression creates an acute shortening of the diameter across the pelvis. When the patient saw the sign for severe injury, please let the patient in close of the pelvis, do not open, because that the patient become worse. The second type is anteroposterior compression. This is the second most frequent cases. In this case, the pelvic diameter is widening, and then the injury can be completely ligamentous without any fracture on the bone. Mostly, this type of compression associated with substantial arterial damage, especially from pudendal artery. Vertical shear, usually the force is posterior and superior directing force. This fracture usually associated with the higher risk of hypovolemic shock, about 63%, and mortality rate up to 25%. Clinical manifestation of the severe pelvic fracture, due to the nature of the high energy impact in pelvic ring injury, associated morbidity requires thorough assessment. And the incident of associated trauma include chest trauma, around 63%, long bone fracture, head trauma, visceral organ damage, spine fracture, also trauma of the intestine, around 14%, genitourinary trauma, around 6 until 15%, and open fracture pelvis, around 5%. Yeah, pelvic ring injury can cause life-threatening condition and require a thorough examination, such as ATLS protocol for primary survey, and then followed by secondary survey, including motoric and sensoric evaluation, test for pelvic stability, and also measuring if any leg length discrepancy, performing the rectal and vaginal evaluation, also perineal evaluation. Don't forget to evaluate the specific sign, including the Destot sign, Gray-Turner sign, and also Morel-Lafayette lesion. Diagnosis of severe pelvic fracture can be made by high index of suspicion in patient when he come to the ER, and then ask the mechanism of injury, and then physical examination, radiology examination, usually pelvic AP enough. Sometimes we need inlet and outlet view for confirm the fragment of the fracture. And then the last is CT scan and also angio-CT. CT scan and angio-CT. CT scan allow precise evaluation of the bone injury. Orthopedic operative management planning usually based on CT scan and not on pelvic X-ray. Because from CT scan, especially CT recon, we can find where is the location of the fracture, how communicative the fracture, and we can plan what approach will be used to treat the fracture. from anterior, from posterior, and combination of the anterior and posterior approach. From angiosity, in arterial phase, allow the diagnosis of other injury with high potential of hemorrhage like liver, spleen, kidney, and also mesentery. Arterial phase critical for the diagnosis of pelvic and extra pelvic bleeding. When it happens, this is indication for embolization. Initial management of pelvic fracture. The first is resuscitation, following the ATLS protocol. The second one is about the pelvic fracture itself. When followed by hypothalamic shock, the treatment is stop bleeding. But the question is, where is the bleeding come from? The bleeding can come from thorax, also from abdomen, also in muscle compartment, retroperitoneum, and also the strip. This is the picture of the patient with the car accident. There was developing of the left knee and then loss of blood in the strip. So, evaluating of the abdomen. For evaluating the abdomen, serial examination and serial lab tests are not appropriate. DPL can take time around 45 until 50 minutes, but the result is inaccurate and sometimes false positive. And then the newest one is FAST. This procedure is non-invasive, but the result is operator dependent. CT scan, usually time consuming and need stable patient. CT scan useful for identifying solid organ injury, the integrity of the mesentery, the presence of contrast extravasation, and status of the retroperitoneal organ. FAST examination. FAST is highly specific for intraperitoneal hemorrhage, but has low sensitivity, especially in pelvic fracture. FAST is recommended in patients with unstable pelvic fracture with unstable hemodynamic status. If the result of FAST is positive, this is indication for laparotomy exploration. And then if the result is negative or uncertain, let's consider to perform diagnostic peritoneal tap or LAPAS to evaluate intraperitoneal hemorrhage. If the result of DPL positive, this is indication for operative approach. If the result is negative, this indication for pelvic angiography and embolization. This is algorithm of management of pelvic fracture in emergency unit regarding to AO trauma third edition. I think you can read this one. Yeah, hemorrhage in pelvic fracture. Usually the hemorrhage is retroperitoneal bleeding. When we have the patient with retroperitoneal bleeding, the blood is up to 4 liters in retroperitoneal area. This blood have a tamponade effect, and in this case, direct surgical control is usually not indicated. And the patient usually need early stabilization. The aim of stabilization is to decrease volume of the pelvis, reopposes bleeding surface, and clot formation. Control of pelvic bleeding. To control of pelvic bleeding, we can perform fracture reduction technique. We can perform the angiography and followed by embolization. And also operative control, especially when we have bleeding from the blood vessel. And then the last is retroperitoneal packing. Fracture reduction and fixation. We can perform the fracture reduction by using a pneumatic anti-shock garment. The other modality is bed sheet, usually combined with tapping knees together, especially when we move the patient. External fixation and compressive device, especially pelvic clamp. Pelvic binder or bed sheet. Pelvic binder is reduce the space in the pelvis for bleeding to accumulate and help create a more rapid tamponade effect. This procedure can stop active vascular bleeding. The devices available, including the commercial binder, large towel, and bed sheet. Pelvic clamp. Pelvic clamp we insert in as a posterior fixation. This clamp is designed to reduce and compress the posterior fragment of pelvic fracture. This can be manipulated to accommodate abdominal surgery or angiography. This clamp also may reduce secondary blood loss. Role of embolization. Angiography precisely shows bleeding site. This is to allow definitive therapy of pelvic bleeding. Obvious bleeding is usually seen in only less than 40% of pelvic angiogram, and this happens in 3% of all pelvic fracture. Embolization usually will stop bleeding in 80 until 90% of case. Embolization. Patient with systolic blood pressure below 90 after 2 liter crystalloid infusion, RBC transfusion, and pelvic binder will consider non-responders. And this is indicated for pre-peritoneal pelvic packing and angiographic embolization, as well as placement of external fixator. In several studies, angioembolization is the gold standard to reduce pelvic arterial bleeding. This procedure is definitive, focused, and minimally invasive. Pelvic packing. Pre-peritoneal pelvic packing usually used to treat severe venous bleeding, but carries a risk of infection and other problem. In this procedure, place 3 lap pads on each side of bladder into true pelvis below the pelvic brim and remove after 24 until 48 hours. A combination of pre-peritoneal pelvic packing and angioembolization is required for definitive bleeding control, with EA remaining important for managing the arterial bleeding. Ribois. Ribois is a resuscitative endovascular balloon occlusion of the aorta. Has recently become a popular method for treating life-threatening pelvic bleeding. But currently, there is still evidence to support the superiority of this technique compared with the aortic angioembolization seen in existing case report and retrospective study. A least placement of an on-demand balloon catheter above the aortic bifurcation show promising approach. Management of pelvic fracture itself can be conservative or non-operative management, especially in stable fracture type A, except in open injury. The pelvis is fixed with the pelvic binder and resting. Best rest or traction is not recommended due to the risk of complication. So early mobilization with a walker is preferred, with the patient bearing weight as tolerated on the affected side. The operative management, including placement of the external fixator, performing the open reduction and internal fixation, percutaneous fixation, anterior pelvic, type of pelvic fracture, and how to perform the anterior external fixation. This is the open reduction and internal fixation through anterior and posterior approach regarding to the CT recontraction. The patient location of the fracture is in anterior and also in posterior. Complication of the pelvic fracture, including mortality rate, high mortality rates, pulmonary emboli, deep vein thrombosis, long-term pain and disability, sexual dysfunction, impotence, and also dyspareunia. Conclusion: the pelvic is structural and mechanical stability of the pelvic ring. The most common cause of pelvic fracture is high impact trauma. As time goes by and technological development, the treatment of pelvic fracture cases has developed significantly from initial assessment and resuscitation to definitive treatment technique. Currently, minimally invasive management of pelvic fracture is being developed using the INPIC technique, namely the principle pelvic stabilization. Thank you.
Thank you, Dr. Dusak. Thank you for a nice and interesting topic about the pelvic fracture. So I want to give information to all participants. So the question and answer session will be the end of the session. So we will have our 4 speakers giving us the lectures. And then after that, we open the question and answer session. But if you right now have the question, maybe you can drop the question down in the chat box, as we have here from Dr. Dandi. But still, Dr. Dandi, you have to wait until the end of the session to get the answer. But I invite all the participants to who have question to drop the question down in the chat box. So I will list them down, and also I will give the opportunity after we have all the speakers. So for the third speakers, Professor Wirya has confirmed that he will join us in the last for the last speaker. So I will invite the third speaker will be Dr. Paksi Satyagraha. He will talk about the recent management of urethral and also male genital trauma. But I believe he's in busy time right now. He's still with us today. He's still with us in this session. But actually, we will hear about the lecture from the pre-recorded session, and also Dr. Paksi will be here at the question and answer session if you have any question to be asked to Dr. Paksi Satyagraha. So Dr. Paksi Satyagraha is a urologist who works in the Saiful Anwar General Hospital, Malang, Faculty of Medicine, Brawijaya University. And he is also the consultant of genitourinary reconstructive surgery. He will talk. He will give a lecture about the recent management of urethral and male genital trauma. Please, maybe the administrator to share the pre-recorded session.
Good evening, everyone. Assalamualaikum warahmatullahi wabarakatuh. Salam sejahtera untuk kita semua. Om Swastiastu. Salam kebajikan, namo buddhaya. Greetings from Malang, Indonesia, and before I start the lecture, I would like to introduce myself. My name is Pakri Satyagraha. I work in Saiful Anwar General Hospital Malang. I'm a consultant of trauma and genitourinary reconstructive urology. And it's an honor for me to be here in this webinar. It's an honor to be part of the ICS family. And today, I also would like to thank all the committee who has invited me. Thank you very much to Dr. Pandey Wisnu, also who has contacted me to share our experience in recent management of urethral and male genital trauma. So, the epidemiology, urethral trauma, consists of 1 in 1 million population. This is 1.5 to 10% of all urogenital trauma. For urethral trauma, the most injury is iatrogenic injury, and this is mostly caused by transurethral catheterization. It's a reasonable number. I would show you also our data in Malang. And also, other trauma is straddle injury. This is what causes blunt trauma. For the anterior urethral injury, kicks to the perineum, and for posterior urethra, mostly caused by the pelvic fracture urethral injury. So these are the usual trauma that we encounter in our daily practice. While sometimes we have penetrating injury or gunshot wounds, which in our setting is quite rare. So our center data, if you look at our 10 years data, we know that the iatrogenic trauma is the #1 cause of urethral trauma in our center, and second one, straddle injury, while pelvic fracture urethral injury is the most common cause who giving the high grade urethral trauma, grade 4 or maybe grade 5. So the iatrogenic is basically mostly are a low-grade urethral trauma, while the pelvic fracture urethral injury causing a higher grade of trauma. So in our 122 patients, 82% have anterior urethral trauma and 18% have posterior urethral trauma. That's our epidemiology. Anterior urethral trauma is mostly caused by iatrogenic, and the more severe cases caused by the straddle injury. Well, one of the symptoms are the butterfly hematoma. It's normally caused by the rupture of Buck's fascia, while for posterior urethral trauma, mostly 68 to 84% are caused by pelvic fracture. So urethral trauma for posterior urethral trauma mostly caused by pelvic fracture urethral injury. There are different type of pathomechanism, indirect and direct mechanism, but this is what caused the avulsion of bulbomembranous junction disruption, while the direct, it could cause avulsion of puboprostatic ligament. This is the classification of pelvic fracture. There are many type of classification. I'm not gonna discuss about this. Maybe the orthopedic colleagues could explain more regarding this: anterior, posterior, lateral compression, and etc. So sometimes urethral catheterization worsens trauma of urethra. That is why urethral insertion is basically contraindicated if we suspected urethral trauma, when you have a bloody urethral discharge, when you have a Buck's butterfly hematoma, or patient have a urinary retention after a pelvic ring injury. So we have to be very cautious. And the question is about floating prostate and digital rectal examination. The old knowledge when I was resident, so this is something that quite useful to evaluate the posterior urethral trauma, because we are looking for the floating prostate. Unfortunately, the data shows otherwise. So there is no evidence could support digital rectal examination is significant or sensitive for diagnosing the urethral trauma. So it's not specific, and the sensitivity is quite low. So it's unreliable finding. If we suspect urethral trauma, we have to perform pelvic X-ray, urethroplasty, or retrograde urethroplasty, or we could do a cystourethrogram if we suspected any concomitant bladder injury. So in trauma center where the urologists have flexible cystoscopy, we could use flexible cystoscopy to diagnose urethral trauma. But unfortunately, in Indonesia, in our setting, we don't have flexible cystoscopy in the emergency room setting. So this is the example of our cases, urethral trauma. So there are extravasation of contrast after we do retrograde urethroplasty. So this is where we have to think about doing the diversion. So what about the management of urethral trauma? We look at the algorithm from the guidelines, European Urological Association guidelines, and Indonesian Urological Association guidelines. It mentioned when we found urethral trauma anterior, we should do diversion. We could do suprapubic cystostomy, or in very low grade urethral trauma, we could do catheter insertion. But I would suggest to insert the catheter with endoscopic guidance. Otherwise, we could even jeopardize the trauma even worse. And after that, we should evaluate with urethrography and evaluate whether this patient needs reconstruction or the patient could void spontaneously. While for posterior urethral trauma, it's a little bit more complicated because mostly this patient have a pelvic fracture urethral injury. So basically the patient has to be in a very stable condition. There are ways to deal in acute setting, whether we could do early endoscopic realignment or just do a suprapubic catheter. So this is the debate in urethral trauma, whether we're going to leave the suprapubic catheter and move on to delayed urethroplasty or just do early endoscopic realignment. I will show you the data after this. So this is also the algorithm in our Indonesian Urological Association guidelines. So what I want to say is for early management of pelvic fracture urethral injury, we should divert the urine. So in first stage, just do a suprapubic puncture or suprapubic cystostomy. Then the discussion would be whether it's endoscopic realignment or delayed reconstruction. Because I would never suggest immediate primary repair or open realignment, since the data shows it causes more complication rather than helping the patient. We look at the data. This is the history. In 1997, the urologists tried to do railroading with magnets and everything. Unfortunately, this is unacceptable anymore. These railroadings, open railroading, open repair in the acute setting is not recommended anymore. So in the early years, in the last decades, people are doing endoscopic realignment. A nice paper from the group from Seattle, Washington, shows the early success rate for endoscopic realignment is 22%, which is okay. Maybe it helps, but unfortunately, when they reevaluate and add up the number of their patients, the success rate of stricture rate doing a primary endoscopic realignment is only 9%. So I would not say 9% success is good for the patients. So I don't think this has benefits for the patients. So it means primary endoscopic realignment is not that good for the patients. There are not many systematic review or meta-analysis regarding this matters. So for posterior urethral injury patient, neither primary endoscopic realignment is superior compared to suprapubic cystostomy and delayed urethroplasty. Meanwhile, with the endoscopic realignment, it even gives the risk of higher erectile dysfunction and urinary incontinence rate. So even if we have to do primary endoscopic realignment, how we should do it? In our center, we do it with 2 surgeons, 2 urologists. The patient should be in the stable hemodynamics, 2 endoscopic set. We have to use flexible cystoscope, super fast surgery, not more than 30 minutes, and then put the catheter for 4 weeks. If it fails, then don't do anything delayed to do anastomotic urethroplasty after 3 months. In our center, we have around 22% of posterior urethral trauma, and we did 3 cases, primary endoscopic realignment, and all of them developed stricture. So primary endoscopic realignment is not suggested or recommended by the American Urological Association guidelines, and also in European urological guidelines, it shows that the primary endoscopic realignment has a weak recommendation. So therefore, in our center, we choose to do deferred urethroplasty in Malang. So our center data shows that grade 4 urethral trauma has a significantly higher risk developing urethral stricture 50 times more than other grades. So after 3 months, we should do anastomotic urethroplasty. We reconstruct the urethra. If the patient is stable, patient should be mobile, urine culture obtained, suprapubic cystostomy, white tract, and we have to document the erectile status, and we have to do a proper imaging, retrograde retrography, and if necessary, we should do MRI. So these are the principle of excision and primary anastomotic urethroplasty. I just want to show you briefly about the steps. 1 is bulbar mobilization, 2 is crural separation, 3 is inferior pubectomy. If we need to do more, it's supracrural rerouting, posterior pubectomy, or also doing omental rep. This is the bulbar urethral mobilization through midline perineal incision. We excise the fibrotic tissue and we do a non-tension anastomosis. Sometimes if the patient requires a shorter, it requires a more elaborative step, we could do inferior pubectomy. And if patient needs more free tension, then we could do a supracrural rerouting. In some cases, I have to do a transpubic abdominoperineal approach, and we have to harvest the omental to wrap the anastomosis. These are our cases. So in our center, our success rate of anastomotic urethroplasty is 92%. It's a very reasonable number. So these kind of patients, which maybe a couple of decades ago have a very low success rate, now it could be treated very well. Unfortunately, there are so many complications caused by our colleagues, which doesn't understand the procedure itself. Even in 2014, Professor Santucci from America, he understands that there are general shortage of number of reconstructive urologists in the US. Most patients are getting repeat dilatation. There are many lack of knowledge of urologists to do urethroplasty, and lack of knowledge that urethroplasty is way superior than TVIU. So Indonesia now have around 19 reconstructive urologist consultants, and I'm very happy when we started in 2012. Now we've grown more people. Unfortunately, there are so many complications caused by ourselves. These are some of the patients that come to our centers that need to be repaired. There are this one young patient with pelvic fracture urethral injury, suffers a prostatorectal fistula, panurethral stricture, and we also have some patients with a bulbourethral necrosis. Some patients have a double bladder neck when someone do endoscopic endoscopic treatment directly to the bladder. So these are the cases that could have been prevented if we understand the principle how to treat the patients. Another prostatorectal fistula that treated by anastomotic urethroplasty, and we have to do interposition flap of gracilis muscle. So it's very complicated surgery. After urethral injury, we move to penile fracture. This is quite common in the Middle East. It's very distinctive sound, the popping sound, and after sexual intercourse mostly, the penis having a penile hematoma, swelling, rapid detumescence, and a pain cracking sound. These are the common finding of a penile fracture. We could diagnose this clinically and with the help of ultrasound, cavernosography, or MRI. but also sometimes we need to perform ureterography to exclude the urethral injury. So after that, how should we deal with this? The immediate repair should be performed within 24 hours of presentation, because early operative repair is the key principle of the management. There are many ways to do a subcoronal degloving and ventral penoscrotal incision, which is not many significant, as long as we do a proper repair of the tunica albuginea. There are some studies that the patient with early repair has better complication rate compared to those who have late surgery repair. It's very interesting that if the surgical intervention was performed more than 8 hours, the post-operative erectile function was significantly worse. So we have to repair that as soon as possible. What the guidelines said, we have to exclude the urethral injury. We have to immediately repair and suture the tunica albuginea of corpora cavernosa. That's the most important thing. For testicular trauma, this is very rare. It's commonly caused by blunt injuries, injury to the several protective factor. Actually, this is very rare because testis is very mobile, and these are the findings that we could find. The hemiscrotum, and look at the ultrasound finding. There are heterogeneous echo pattern, intratesticular hematoma, and testicular rupture. So urgent scrotal exploration is definitely what we should do. We have to evaluate, look at the testis, whether there's a laceration or rupture. Then if we could fix this, we could just debride and suture the tunica albuginea, and or if the trauma is severe, then we might to do orchiectomy. So there's a very nice paper regarding the long-term functional outcomes. It's not it doesn't have a big number, only 7 patients, but the interesting is all patients have a normal spermia after 6 months post-injury. So after they do debridement and early repair, so the normal they have a normal sperm, and also they did not develop anti-sperm antibody. So it's just show if we have a patient with testicular trauma, as soon as possible, we have to repair that before 72 hours. Penile amputation is quite common. It's not that common, sorry, but very difficult to treat, especially in Indonesia. We have so many penile amputation caused by circumcision. I think in every trauma recon center in Indonesia have at least 1 or 2 cases per year due to circumcision. So this is very difficult to treat. In other part of the world, these are also caused by circumcision, but also penile amputation could caused by schizophrenia or domestic violence. So management of penile avulsion is basically resuscitate the patient, and we should do reimplantation before 24 hours of after 24 hours of amputation, before 24 hours of amputation. So the penis should be the stump should be transported in a proper way. I will show you later. And pressure dressing and tourniquet should be placed around the penis, and reattachment could be done in microscopic or non-microscopical way. The reimplantation should be done immediate, and anastomose the vascular urethra. We should try to restore the erectile function restoration, and the recommendation is doing this prior 24 hours. So the amputated should be retrieved, cleaned, and preserved, washed either with saline or flowing water, wrapped in saline gauze, put it in a plastic bag, and the first bag is then placed in a second bag containing a slush of ice. So the penis is not directly touching the ice. So successful replantation has taken place 18 hours following surgery. Injuries up to 24 hours can be replanted, and if the part has been carefully preserved. beyond 24 hours, sometimes the results is lower. There is an increased incident in erectile dysfunction as well as urethral stricture in patient that was performed reconstruction or repair or reimplantation without microscope. So microscope is more recommended. Delayed reconstruction, partial implantation, and this could be done if the patient was transferred a long time after the trauma. And actually now it's growing. There are a lot of ways to create a penis in Europe, in America. Phalloplasty using radial forearm free flap is quite common. And for erectile function, we could put on a penile prosthesis. And there are very interesting methods also performed in South Africa, in America, in China, penile transplantation. Unfortunately, until now, the result is not that good. So, in conclusion, the field of urethral trauma in urology is constantly evolving. In urethral trauma, my recommendation is in pelvic fracture urethral injury, superior pubic cystostomy placement and delayed urethroplasty is a choice. Primary endoscopic realignment is no longer recommended. Also, early realignment or railroading, it's already abandoned. So in the hand of the experienced surgeon, reconstructive surgery, posterior excision and primary anastomosis for pelvic fracture uterine injury has a very high success rate. Genital trauma is quite rare, but sometimes could give a long-term quality of life deterioration. And in penile fracture, immediate surgical repair is the first option. In testicular trauma, early and immediate repair also should have been done. And penile amputation, the stump should be correctly preserved, and then primary reimplantation should be done before 24 hours. That would be my conclusion for today. Thank you very much for including me in this prestigious webinar. I hope I could contribute further for the ICS in the future. Thank you very much, everyone, and thank you very much to my team, Dr. Jemmy, Dr. Dipta, Dr. Rian, Dr. Bimo, Dr. Gupta, and Dr. Roy. Thank you very much for the opportunity, and I would be happy for some question for discussion. Good evening.
Thank you, Dr. Paksi, for this pre-recorded lecture. It's always enjoyable to hear your lecture, as always. Right. Thank you for sharing your experience also. So before we move on to the question and answer session, so we still have one speaker, the last but not the least, Professor Gede Wirya Kusuma Dwarsa. I believe he's still in the EOR, but thank you, Professor Wirya Dwarsa, for accepting our invitation. So he will talk about the recent management of kidney, ureter, and bladder trauma. Professor Gede Wirya Kusuma Dwarsa is the urologist who worked in the Prof. Ngurah General Hospital, and he also the consultant of pediatric urology. Please, Professor Wirya, the time is yours.
Dr. Pandey, could you hear me?
Nice and clear, Prof.
Okay.
Please,
Thank you, Hani.
please continue.
Okay. Good evening, everybody. Thank you, Chairman. And sorry for being annoying. Sorry, because I have just returned back from the Java, and then I have something emergency cases, as usual, as a surgeon. Okay, I would like to try to present our topic for discussion: recent management of kidney and ureter and bladder trauma. I'm Gede Wirya Kusuma Dwarsa, as explained by Dr. Pandey Wisnu. I work in the same university with him, Udayana University. Also with my Professor Sri Maliawan. I have no conflict of interest. At the right side, we can see the picture of the kidney, ureter, bladder, also external genital, prostate, and urethra also. That already been explained by the Dr. Paksi Satyagraha, one of the greatest urologists here in Indonesia. Very, very well, thank you. And then now we are going to discuss another emergency about the kidney, ureter, and bladder. Actually, if we compare to other surgical fields in the surgery department, the emergency in urology part is very less. So at the left side, we can see some emergency in urologies, and now we are going to discuss about trauma. This accident is very occurs common in Indonesia. I take it from the YouTube. We can see pedestrian and vehicle collision is very often here in Indonesia. And then Dr. Paksi also already have the data how many motorcycle here in Indonesia. He is a very good man with data motorcycle in Indonesia. Most of the urogenital trauma occurs in the male one and younger patient. 1.5 to 3.5% of all trauma occurs in urogenital trauma, which is 10% of them are abdominal trauma. More than 80% of the kidney trauma are blunt trauma. So in Indonesia, penetrating trauma or gunshot trauma is very rare. Kidney, with its smallest function, we call it as a nephron, is a well-protected organ who are placed in a high retroperitoneal species, which is protected by the visceral organ in the front side from the liver, from the spleen, and also for the thick abdominal wall in the front side, also from the lateral side. From the back one, there are a strong muscle and then also spine also and ribs. So less likely that the trauma will occur in the kidney unless the trauma is a very major one, or the kidney itself has the abnormality. As I explained before, that the kidney which is placed in retroperitoneal is covered by the fat and the retroperitoneal species, and also covered by the strong gerota fascia. And the attachment of the kidney in our body due to the artery, aorta, and also intravena caval vein, and also from the pedicles and the UPG as well. So there are two pathomechanisms of the kidney injury. First of all is the direct blow for the kidney, and the second one is because of acceleration and the deceleration forces because fell from the head. And those pathomechanisms will cause the rupture of the thrombosis, sometimes also rupture of the arteria or vein of the Renal. This is the picture how the direct blow happened. And also at the left side, we can see the gunshot or stab injury. According to the EEST, the kidney trauma can be divided by 5. The first one is the contusion of the kidney, and the second one is minor laceration, which is less than 1 centimeter. And the third grade is the laceration of the kidney 1 centimeter or more, but not penetrating to the infundibulum. This is the fourth grade, and the last grade is the severe kidney or the affusion of the kidney pedicles. If we would like to establish the diagnosis, so we have to carefully take the history of the trauma, comprehensively try to find the mechanism of injury, and also we have to find out whether there is or there is no hematuria, flank hemosis, rib fracture of the costae, mostly at the 10th and 12th of the costae, abdominal masses, and abdominal tenderness. Imaging test that will support the diagnosis is the easiest tools to do, and the cheapest one also that can be done everywhere and by every single surgeon, every single doctor, is the ultrasonography. From the left side, we can see the fragmentation of the kidney from the ultrasonography, and at the right side, we can see also the rupture of the kidney and the free fluid here in the abdominal cavity, also surrounding the kidney. The other good examination imaging that will support the diagnosis is the single shoot IVP. Single shoot IVP is very, very good if you can do it in the emergency room, especially to the patient that would like to go to the OR for emergency setting. Then we just have to inject the contrast and then directly send the patient to the radiology, take a photograph, one photograph, and in very, very fast we send the patient to the OR, and then at that time we will see the contour, the picture of the kidney. We can see at the left side this is the normal kidney, and the right side we can see that there is at least grade 4 fracture of the kidney. Of course, the gold standard of the imaging to perform the diagnosis of the kidney trauma is the CT scan with contrast. This is an example of the patient 16 years old in my hospital. It was of course in 2020 from direct trauma traffic trauma. You can see from the CT scan here, the right kidney so very okay, and then we can see the at the left kidney, sorry. At the left kidney, we can see the fracture of the kidney, trauma of the kidney grade 4. We can see the trauma of the kidney grade 4 here in the left side. From the from the axial view, we can also see the fragmentation of the kidney. We can see here the hematome here. This is the hematome and this is the kidney. So what is the management of the kidney trauma? For the grade 1 and grade 2, less likely that we will do the renal exploration as the first indication. Most of the patient, and I can say that according to my experience, 100% of this patient grade 1 and grade 2 are treated by non-operative management. Of course, once if we have the major trauma, we have to concern about the advanced trauma life support principle from the airway, breathing, and circulation, etc. For the kidney itself, the main principle is we have to try to as much as possible to renal preservation and minimize morbidity. So what about grade 3? Most of the grade 3, according to EU guideline, from BBGU guideline, most of them are treated by non-operative management. And in some cases where the blood is still going on, come from the urine, then we do the angioembolization for as indicated only. For the grade 4 and grade 5, most of grade 4, years ago, grade 4 suggested to do the surgery, but nowadays, even grade 4 for blunt trauma, mostly treated by non-operative management. And non-operative management, it was said that the success rate more than 82%. Even I will show you some serial cases that published by our best friend. Even grade 5, we can treat it by non-operative management. This is the EU guideline to 2024. If there is a renal trauma suspicion, then we have to determine is the patient in stable condition or not. Is the unstable? Usually we are going to go to the exploration. In the emergency setting, nephrectomy is frequently done by our colleagues, also by me myself, but hopefully that we can do the renal preservation. In the stable condition, we can see if there is non-visible hematuria. Most of the cases can be treated by non-operative management. If the visible hematuria, then we have to go further for CT scan, for the angiography, and in some cases we have to go for renal exploration, do the renography or the nephrectomy. According to the EU guideline again, non-operative management and close monitoring and also re-imaging is indicated for a stable patient with blunt renal trauma, also gunshot wound or the low facility gunshot, and also stable isolated for grade 1 and to grade 4 step injury. Angiography for active bleeding is suggested also, and in many cases, we have to insert the diversion, whether we use the nephrostomy, we use the stenting. And then this is, we have to go for the renal exploration if there is a persistent hemodynamic instability, grade 5 vascular or penetrating injury, and expanding or pulsating perirenal hematome. If we do the also concomitant injury for the abdominal trauma, then we do the we can see from the exploration of laparotomy, we see the pulsating and expanding retroperitoneal spaces. Then we have to go to retroperitoneal approach and try to find the kidney rupture. What should we do in non-operative management? First of all, we have to do the clinical evaluation according history taking anamnesa, and also the check the vital sign, hemodynamic, flank area, whether there is hematome, enlarging hematome, expanding hemosis, and also hematuria. And supportive care and fluid resuscitation is mandatory. Analgesic if needed only, and the antibiotics is not mandatory, but if there is a grade 4 or grade 5 where the urine extravasation from the pelvic system, then we suggest to do the to give the antibiotics for that one, and bed rest, of course. And laboratory evaluation that we suggest to do is the urinalysis, complete blood count, creatinine, and also the creatinine level for observation the kidney function. Imaging, as I mentioned before, ultrasonography, IV, and CT computerized tomographic scanning. Again, if we decide to do the non-operative management, so reassessment, and of the overall condition of the patient. Minimally invasive procedure for continuous bleeding from the urinary tract is suggested to do the TAE, angioembolization, or urethral stenting. So if the hemodynamic still unstable, then we should think about the exploration. If we need the fluid, increasing the fluid replacement, or the persistent bleeding, and massive urine extravasation, extensive the non-viable renal tissue, or penetrating injury that pass through the fascia, or fail minimally invasive procedure, then we suggest to do the exploration. In the acute condition, the best one is the transperitoneal approach, but in the few days after the trauma, we also can do from the retroperitoneal approach to preserve the kidney. Laparotomy, again, according to the European and also the American Urological Association, was suggested if there is a continuing hemodynamic instability, unresponsive to aggressive resuscitation, or expanding or pulsating perirenal hematome. This is from the American Urological Association guideline 2020. Some of the points that I would like to underline is computerized tomographic scanning for stable blunt trauma patient is the gold standard. And then we suggest to do the IV contrast, at least the ultrasonography, if we think that there is a renal injury, whether there is from the rapid deceleration or direct trauma or penetrating trauma. In hemodynamically stable, that non-operative management is suggested. And then the surgical team, the surgeon should be prepared for immediate intervention. Minimal intervention is suggested if there is continuous bleeding using the angioembolization or the drainage, and follow up CT scan again and again for the non-operative management. And then if there is a complete renal fracture like this IVU and also expanding retroperitoneal hematome, then we do the surgery. This case, we can see the grade 4 of kidney trauma. Then we do the renography. We stitch the calyx, close the calyx, and then close the do the renography. as I mentioned before, there are 3 cases for grade 5 renal trauma that was presented by Mr. Paksi Satyagraha with his student also Dr. Busuk Daryanto. We can see that this is grade 5 complete avulsion of the upper pole of the kidney that was treated by the non-operative management. And then the other big hematome also treated by the non-operative management with drainage from using the double G stent. And the third cases of Dr. Paksi and friends also presented here. And all of 3 patients in a very good condition, okay. And then still we have to go for further evaluation for long-term complication. So this is the early complication of the kidney trauma. First is the bleeding, infection, perinephric abscess, sepsis, etc. Also including the acute kidney disease. And delay complication that should be followed up by Mr. Paksi and his team. Is there any subsequent chronic pyelonephritis or not? What about hypertension and what about the kidney chronic kidney disease for non-operative management for grade 5 of kidney injury? Now we are going to go to the second organ is the ureter. The trauma of the ureter is very rare, less than 1% of the urogenital trauma. And the Western country, more than 90% caused by the gunshot or stab wound. But in Indonesia, ureter trauma due to stab wound or gunshot is very, very, very low. Most of the ureter trauma caused by our colleagues from gynecologists or ourselves as from the endoscopic procedure. I believe that Dr. Paksi and also Dr. Pandey have 1 or 2 experience of ureter injury due to their aggressive endoscopic procedure. And then the pathophysiology is the ureteral ligation, ureteral rupture, obstruction. Then this injury will cause the renal function decreasing or peritonitis and also the fistula. The fistula in the female one, sometimes the symptom as the ureterovaginal fistula. Patient have the continuous leaking but they still able to pee because of the other side of the contralateral of the ureter is still okay. So this is the pathophysiology of the ureteral injury. The symptom is very general flank pain, fever, nausea, vomiting, urine leaks, and anuria. And the sign sometimes, if as I mentioned before, for the ureterovaginal fistula, we will see the incontinence. Imaging, it's hard for me to suggest you to do the ultrasonography or CT scan, but the BNO or IVP or RPG will reveal that according this IVP, we can see the kidney function is okay, the upper part of the ureter is okay, but there is the leak here, the extravasation of the contrast. So the perforation is here. What should we do for the proximal ureter? We can do the primer ureterostomy. In some cases, if we lost a very long of the ureter, we can do the bowel replacement for that one. For the middle ureter, most of the cases, as far as I know, that we can do the ureterostomy as long as we can identify the distal part of the ureter and also the proximal part of the ureter, and most likely we will able to do the ureterostomy. And then in a very rare case, we should do the transureterostomy across the midline of the body midline. And for the distal ureter, we can do the ureterostomy primaire or new implantation if we have the residual ureter quite long using the psoas, etc. And in some cases, we also do for several times, we do the bladder tube flap or Guari flap. Okay, at the right side, that here I have already explained it at the previous slide. I would like to stress, to underline here to our colleagues, hopefully that there are some of our OBGYN colleagues use the preoperative or prophylactic stenting in high-risk cases. In high-risk cases such as the huge abdominal masses, or also from our digestive surgeon, my colleagues from Malang, doc. If a very huge huge masses, and then also from the CAT scan, there are many infiltration to the distal part of the body. It is suggested to use the prophylactic stenting in high-risk cases. The recommendation is strong. And then, of course, for the iatrogenic ureteral injury, we can do the nephrostomy tube or double G stenting after we do the freshening of the ureter. And the last topic is the bladder. We know that there are two types of bladder injury. First of all, the extraperitoneal bladder injury, and the second one is intraperitoneal bladder injury. Extraperitoneal bladder injury can be caused by the segment of fracture segment from the pelvic bone, as mentioned by my senior colleague, Dr. Suryanto Dusa, and also from the step injury or iatrogenic. I believe that my colleague, Dr. Pandey, also do the iatrogenic for the bladder rupture, I believe. And the second was the intraperitoneal bladder rupture that occurs in a very in the full blast, and then we know that the weakest point of the bladder is at the dome, and then the direct injury to the full blast will cause the rupture of the dome. Then there will the intraperitoneal bladder rupture. Also, of course, step or gunshot injury can cause extraperitoneal or intraperitoneal bladder rupture. Again, comprehensive history taking is mandatory, and physical examination we can see from the slide, the laboratory finding, and then I would like to stress the imaging, cubic kidney ureter bladder photo or a big overseas photo or the plain photo abdomen will reveal the pelvic bone fracture and also the hematoma of the pelvic cavity. To find out whether there is or there is no blast injury, then we have to perform the cystography. Even the specificity is not so high, because if we fulfill the bladder not more than 250 cc, then sometimes the intraperitoneal bladder rupture could not be assessed using the less than 200 cc of contrast, because the momentum from the abdominal will close the dome of the blast. So we have to fulfill the blast, the bladder, more than 200, 250 cc contrast. Then we will see from the X-ray or CT scan even better. Then we can see the contrast will fulfill the abdominal wall beside the intestinal. This is the classification or grading of the bladder injury: contusion, laceration, and grade 1, 2, 3, 4, 5. For the intraperitoneal bladder rupture that's less than 2 centimeter, we categorize as grade 3. If the laceration is more than 2 centimeter, we can say that grade 4 of the bladder injury. Okay. And if the laceration extend to the trigonum or urethra, we should say that this is grade 5. Then it will be a very, very difficult cases. Then we should refer this patient to Saiful Anwar Hospital. Dr. Pasi will repair that one. The management, emergency for the shock management, and definitive, as I mentioned before. So this is from the Indonesian Urological Association guideline for the blunt trauma of the kidney. We can see from here. If unstable, of course, do the laparotomy. If the stable, we have to find out whether there is extraperitoneal or intraperitoneal bladder rupture. Intraperitoneal bladder rupture should be shown as a primary condition, and the extraperitoneal bladder rupture, we can do conservative treatment or the aggressive treatment. For the penetrating trauma or gunshot, we should do the exploration. And for the iatrogenic trauma, if we do the TUR of the bladder, we do the helic evacuator. Sometimes we will have the complication, bladder rupture complication. So if we know it intraoperatively, do the bladder repair. If after the procedure, if we did not realize the complication, we do the cystography. Again, we should follow the previous chart. Okay. And then this we call it this oplet. This BEMO is in Bali years ago, whose that speed not more than 20 to 30 kilometers per hour. If we go back to use this car to go to Malang, then I believe that there will no kidney injury or bladder injury in Indonesia. So again, thanks you, Dr. Pandey. Thank you, the committee. And then again, I would like to ask you a very high apology because of my my annoying. Sorry. Thank you.
Thank you, Professor Wirya. Thank you for the informative lecture. So now we move on to the last session, the session of the question and answer. So for the first opportunity, I will give time to our panelists, Dr. Ana Agung Gede Oka. Please, Dr. Oka, if you have any question or comment regarding the topic for today, please. Dr. Oka, you're still mute. Please unmute yourself. Sorry.
Thank you, Mr. Chairman and Dr. Pandey. Maybe you can, I can speak in Bahasa on English, yeah?
Yes, please, in any language you want.
Okay. All of me in physician maybe know about the anatomical relationship between the skeletal and connective tissue of the pelvis, neurological, vascular structure, and pelvic organ are the processing factor for the structural and functional damage of the genital organ. My question is, Dr. Dusa ya, ada di sini ya?
Ya, ada dok.
Yeah,
Still here.
thank you. Yeah, my question in Indonesia ya. Dr. Dusa, if a doctor in primary care physician,
Yes.
if the patient come to my puskesmas with the pelvic fracture and the shock and the blood pressure is low, what the primary care we must do before I refer to go to the hospital, maybe Sanglah Hospital? Yeah.
That's all, Doctor. Yeah, thank you for the question from Dr. Nagomoka. In patient with pelvic fracture with shock in primary care, I think we must first do the fluid resuscitation and then make the stabilize of the pelvis itself by what can we do there, especially using the binder or wrapping, Doctor. The aim of wrapping is to make the pelvic volume can be stable, and then after that we evaluate again the vital sign, if rapid response, and then we try to hold that position and send the patient to the Ngurah Hospital if the patient is stable. If still still unstable, I think we try to examine again what did happen, and then after that give the blood transfusion and everything like that, and if the patient stable, we can send the patient to the hospital. Mungkin begitu, Dok.
Yeah, thank you, Dr. Dusa. Dr. Panewisnu, maybe I can continue the question to Professor Wirya.
Yes, please. One more, maybe one question, Dr. Oka, because of the time constraint. Yes, please. Just one question. I'm sorry.
Professor Gede Wirya, we have one question. Maybe all of the doctor here in primary care physician can hear here in this discussion. Professor Gede Wirya, the young male patient with the pelvic trauma with the retention of the urine, what the first we must to do in the primary care physician.
Yeah, thank you, Dr. Oke, my senior colleagues in our department. Very, very good question, actually. And then actually, this question is for the Dr. Paksi question, actually. But I would like try to answer as much as I can. Pelvic fracture trauma is a major condition trauma. It's a major trauma. So if the more than 15% of the pelvic trauma, 10 to 15% of pelvic trauma is followed by the urethral trauma. Dr. Paksi would like you have to explain it again. But the in the opposite statement that more than 90% of the urethral trauma for the postural urethral trauma is caused by the endoscopic procedure, not the pelvic trauma. Pelvic trauma can cause 15% of the urethral trauma. If the so if the patient come to our hospital with retention, urine retention, pelvic trauma with urine retention most likely caused by the postural ureteral injury. Then in that case, we may do the formal cystostomy, because in my opinion, suprapubic puncture is not suitable for that patient due to the floating bladder. Then we do the formal cystostomy, try to find out the bladder and put in the catheter, suprapubic catheter. And then me myself, even it is still a big controversy for that one. When we do the primary endoscopic alignment less than 2 weeks, in many centers like Dr. Paksi, he already set up from his seat. He will not do that one. He will do directly the second look 3 months after the procedure, do the urethral repair. Is that right, Dr. Paksi? I know that you are going to sit up. Okay, Dr. Paksi, the time is yours. Dr. Oke, the question is not belongs to me, actually. This is the Paksi. Okay, thank you.
Yeah, thank you, Dr. Professor Widya. And maybe I continue with Dr. Paksi, yeah?
Yes, Dr. Paksi, you may add something regarding
So,
to the question.
I just don't get the question quite clearly, whether the retentions is due urethral trauma or pelvic fracture, or is this normal retention, Dr. Oke?
Yes.
Apakah artinya
Yeah.
karena trauma atau karena ini, Dok? Maaf, Dok.
Pelvic trauma, and the patient come to our
young male.
Young man, 17 years old male like you, come to our hospital.
I just don't want to have a pelvic trauma. I don't want to have a pelvic trauma. So basically, I just want to try to elaborate the answer from Dr. Dusak, Professor Duarse, and all the experts. Basically, all the trauma should have been treated in the principle of what we know as the advanced trauma life support. So we basically have to understand that the first important thing is the primary survey, the initial assessment. So everything should be hemodynamic stable. But if the patient in C, in circulation, there's a saying, there's a theory that we have to put a too large bore of IV line and put a catheter as long as there is no contraindication. So if we found some contraindication, please don't, for example, like bloody urethral discharge, and then butterfly hemoptoma, urinary retention. So just please don't put any catheter. So diverting the urine is secondary. As long as the patient is stable, then the primary physician could refer that to the secondary or the tertiary. So when I did my residency under the mentorship of Dr. Oke, Dr. Geweka, there's a kind of theory that in trauma it's forbidden to perform suprapubic cystostomy, which is, I don't think I'm not agree with that statement,
because like this moment, even digital rectal examination is not reliable to diagnose urethral trauma. So even suprapubic puncture is okay as long as the bladder is palpated. But if the bladder is not palpated, just leave the patient. Even as long as the patient is hemodynamic stable, just refer the patient. That's for primary physician. But for secondary or tertiary physician, if we found someone with urethral trauma, then suprapubic cystostomy is the best option for everyone. So I think in many tertiary emergency department, we have ultrasound. We could do suprapubic cystostomy under ultrasound guidance, so it's very safe. So there is no problem. You don't have to do open cystostomy as long as the patient, the bladder is full and you have ultrasound guiding. So everything you can do it. We could do it. You could do it percutaneously. So for physician in the primary care, what I would suggest is don't do anything. Don't put a catheter. Don't do anything. Just stabilize the patient. If the patient have a pelvic fracture, just like Dr. Dusak say, just put a pelvic bandage, because it's basically in the initial assessment, because you cannot do any surgical resuscitation in the primary care. You should stabilize in the and then you refer that to the secondary or tertiary hospitals. But for someone working in the emergency department, the secondary hospital or tertiary hospital, you could do a suprapubic cystostomy if you have urethral trauma. If you please use ultrasound guiding, you just don't have to bring the patient to the OT. You could do a suprapubic puncture with ultrasound guiding. That would be my suggestion, sir. Thank you very much for the question, Dr. Oka, Dr. Wirya.
Okay, Dr. Panevisnu, we can continue question to Dr. Paksi.
Maybe we just give another person to give
Thank you.
the question. I'm really sorry, Dr. Oka. Really sorry. So since Dr. Guido Parquet is still here with us today until the last session, I will give the opportunity next to Dr. Guido Parquet if he have any comment or any question to all the speakers. Please, Dr. Guido Parquet.
Yes, this was a very interesting seminar. I stayed to the end because it was very interesting. This is we have an epidemic in Paraguay also of trauma, and especially motorcycle trauma. So and the primary care is very important. So what I think is that what all the speakers told us today, and basically how to treat in primary care facilities so that we can help the patient and not injure more the patient trying to help them. That is very, very important. So I really congratulate every one of the speakers. It was very interesting. It was very useful, at least for me. I'm a general surgeon. I do a lot of percutaneous ultrasound guided procedures, so I can do the cystostomy percutaneous in the case that it is needed. So thank you very much for the invitation. This was for me very useful. I'm sure it was very useful for all the participants. And keep this good work in the Indonesia section, because this is what we need in the International College of Surgeons. With this kind of activities, we will fulfill our mission, that is bring health and better conditions to our patients through the education of our members. Thank you very much, and congratulations to each and every one of you.
Thank you, Dr. Guido.
Thank you, Dr. Parquet. Thank you very much.
So I think we still have several questions from the chat box. I just limit that into just 2 questions from Dr. Let's say, right, okay, from Dr. Dandi. So I think this is the first question I think it's addressed to Dr. Dusak. Dr. Dandi, so asking about the role of DSA to control bleeding in pelvic fracture, and also what is the indication and how effective is the DSA? Please, Dr. Dusak.
Sorry, Dr. Pandey. Oh, what they asked to me?
Right. Okay. So I will read about the question from Dr. Dandi Tanuwijaya. Good evening. I want to ask about the role of DSA, embolization to control bleeding in pelvic fracture, and what is the indication, when to do the DSA, and how effective the DSA is. Please, Dr. Dusak.
Yes. Okay. The embolization is indicated for if the patient is still in shock, yeah, and then when we perform what is the angiography we perform after the fast and everything is negative, yeah, and then also in DPL also negative. That's the indication for angiography, and then when by the angiography we can know about where is the bleeding source come from. Then from there we did the embolization. So the embolization is the best treatment if we suspected if we know about the source of the bleeding is come from the arteria. Yeah. When we perform the open laparotomy, when the blood is not in intraperitoneal but retroperitoneal, I think the choice is not embolization but packing. So the angiography embolization just performed when the patient is the angiography embolization is when the bleeding come from the arteria. I think that's.
Thank you, Dr. Dusak. Thank you for the answer. So maybe because of the time constraint, I just limited the question and answer just for one more question from the chat box. It's again from Dr. Dandi Tanuwijaya. It's addressed to Dr. Paksi regarding the post-URP urethral stricture might related to big resectoscope around 26, 27 French. And then he said that he'd routinely dilate the urethral prior to TURP. And also he preferred to put in large catheter large catheter in patient with urinary retention, which might caused by BPH to anticipate future TURP in order to gradually dilate the urethra while waiting for TURP. And what is your opinion on this? Maybe this is regarding the large bore of catheter that can make the the ischemia of the urethra. Please, Dr. Paksi.
I got the point of your questions. Dr. Dandi is my very good friend from Bandung. He's a very good surgeon, and so what I could say is, post-URP stricture is quite common. We encounter quite a lot of post-URP stricture in our center since we are a urethral recon referral center. And there is a nice paper from the group from India, Professor Kulkarni and Dr. Joshi, shows data from their TURP strictures, which it's true. It might be related to the size of the resectoscope sheath. So the larger, it could it basically have more risk to develop stricture. But unfortunately, that is not the only factor. There are some other factors, what it's called the cheese grater effect. In continuous sheaths, there are some holes in the sheath. So it is also could cause the cheese grating effect in the urethra. And then the other thing is electrical leakage from the resectoscope, especially when you do monopolar. So it could cause more problems. And then other things are the size of the prostate. The larger the prostate, it causes, it has more risk to develop strictures in the future. So it is not only one factor, which is true. The large size of the resectoscope sheath is one of the risk. So to minimize that, I mean, gentle dilatation is okay. Like I also do a gentle dilatation initially, but please do not force. So the most important thing is if we could do as small as possible resectoscope sheath, it would be better. So that's one thing. Secondly, we should minimize the time of the surgery, and also because in Indonesia we actually non-dispose the disposables loops, so it could also causing the electricity leaks. And then there are many other things. And about the large catheters, and it's also another paper that is very good, published somewhere, I forgot. If you look at the 26 French resectoscope or 27 French resectoscope, but if you really count it, you really measure it, actually the one that was told by the company is larger than what it's supposed to say. So that's funny, because like 26 French is actually 28 in reality. You should measure it. There's a paper also from those the Kulkarni group. And about the catheter. So since I am a urethral surgeon, so I really take good care of urethra. I don't believe the large size of urethra is beneficial for us. All of my patients, I put only maximum 16 French. Mostly are 14 French, because I don't want to jeopardize the urethra in Indonesia, especially because this 18 French catheter that was written in the textbook is actually written by the German a urologist, a German expert with a German penis. I don't think the Indonesian penis has the same size of the German, the African, or maybe only the Professor Geweka has the same size as the Sudanese, but other Indonesian basically have smaller. So I would not put a larger catheter. So I would always put a smaller one. Even for TUR, I always do 20 or 22 French 3-way catheter. So don't jeopardize the urethra using a large bore, a large size of catheter, because when we do urethral surgery, for example, the catheter is not for dilating. The size, the catheter is only used for splints, and the bigger the catheter could cause more ischemia. The smaller, it could create some space between the catheter and the urethra. If there's some blood, it could come out. So I just completely not agree putting a larger size of catheter to someone's urethra. So I would go with 14 French for Indonesian, but maybe for European, for African, or maybe for Caucasian, it could be a bit bigger, 16 to 18 French. So that would be my comment, Dr. Wisnu. Thank you very much.
Thank you, Dr. Paksi. So I think Dr. Dandi also asking Professor Wirya about the embolization, regarding the trauma of kidney, and also Prof. Geweka has already answered that in the chat box. Prof. Geweka, do you want to add something regarding this?
No, thank you.
Right.
Embolization, okay. Embolization is not only for the trauma, but in our field also, Dr. Paksi and Dr. Pandi Wisnu, Rumi, myself, we also Dr. Roke Huduan that performed the PCNL very many years ago. So in some cases, thanks God, not in my hand. Some cases after the PCNL, we have the continuous bleeding, and at that point, the embolization is also very good to be performed. And then I have one also patient from my colleagues of surgery who do the nephrolithotomy, and then the bleeding is continuous bleeding. Then we do the embolization. So by doing the embolization will decrease the the exploration needed. So embolization is very good one, and thanks God we are in our hospital. We have already 3 of the vascular surgeons. So yes, embolization is good one. Thank you.
Can I
Okay.
add up to that data, Dr. Vishnu, since
Yeah.
Professor Wirya has cited
Yes, please.
our publication? It was so we publish a case series of 3 grade 5 kidney trauma. One, we didn't do anything, and the kidney amazingly spontaneously resolved after 3 months. The second one develops a large urinoma, so we did only a digistent placement, and also we did only a percutaneous drainage. And the third one, there's more bleeding after 72 hours. So we did angiography and we did super selective embolization. So there are so many ways to treat this patient non-operatively, not only embolization. Embolization is only one of the tools to take care of this high-grade renal trauma. So we just published 3 cases of grade 5, but we have also other grade 4 kidney trauma, which treated conservatively. The last time I did nephrectomy for kidney trauma was 2018, and it was only 3 cases of nephrectomy in the last 10 years. I hope I could publish the data in the very near future. We have the 10 years data. Thank you very much.
Thank you, Dr. Paksi. Thank you, Prof. Wirya, for the answer. I think we have to end this session because it's the time is very limited. So I will say thank you to all the participants. So actually, as Professor Sri Maliawan said at the beginning, it's not around hundreds of participants in the first place, but I have information. In the first place, we have submission from 6,000 participants, but because of the the government policy, so that's beyond our ability to handle. So we have to limit the participant. So we're really sorry to all the participants who cannot join this webinar. So I will say thank you to all the participants from the beginning until the end of the session, and also we will extend our gratitude also to all speakers, Dr. Setio, Dr. Paksi Satyagraha, Dr. Suryanto Dusak, Professor GWK Dwarsa, for the interesting topics that they already given to us. And also for panelists, Dr. Anagung Gedeoka, until the end of the session, and also Dr. Guido Parket, who joined from the beginning until the end of the session. And also I will extend our gratitude also to organizing committee who makes this webinar happens, Dr. Rusdi, Dr. Maria, Dr. Astri, Dr. Henry, and Bli Pande also. So for the last speech, I will give the honor to our boss of ICS Indonesia, Professor Sri Maliawan, to give the closing speech and also to close the session. Please, Professor Sri Maliawan.
Thank you, Dr. Pandi Vishnu. It's very interesting. We have 4 distinguished speakers. I am a neurosurgeon, but I am still interested in what evaluate and flashback when our resident and medical school. It's very interesting. Or it because same you have lower head and mimicking lower head and head itself. So thank you again, Dr. Rocco, Dr. Professor Guido. Thank you from. It must be early in the morning right now. Yeah.
No, it's 10 o'clock in the morning.
Oh yeah, thank you. Again,
Saturday, 10 o'clock. So it's good.
Thank you again.
Good time for me.
And then last but not least, all of the participants, thank you for your following this webinar from the beginning until the end of the Q&A. Again, thank you, and also the committee who work behind the screen. Thank you very much, Dr. Rocco, and so on. Dr. Paksi also, we have very distinguished speak and distinguished talk, very interesting. Thank you. So now, with all of you, I close this webinar, and thank you. I appreciate it very much. Thank you. Yeah, please. Good night. Good.
Thank you. Good
Thank you.
evening.
Thank you
And
very much.
have a good
Dr.
weekend.
Sukma, Prof. Wirya, Dr.
Good
Oke,
night to
Dr.
everyone.
Thank you very much.
Thank you,
Prof.
Dr.
Thank
Fadli.
you.
Maliawan.
Now it's 10.
Dr.
15 minutes past 10 in Bali. Okay.
See you.
Okay. Thank you.
Terima kasih. Terima kasih.
Terima kasih semuanya.
Bye.
Salam Swastiastu. Assalamualaikum.
In
Don't forget, next 2 months, there is also a webinar. And then if somebody want to talk, please send your title and your PPT.
Curriculum vitae also. Yeah.
Okay. Thank you. Okay.
Yeah. Thank you.
Please,
Good
you can
evening.
leave now.
Have a good weekend.